give more fluids if the patient takes it, or add an inotropic agent like dobutamine or levosimandan. So we have to work on this U-shaped curve. We don't want oxygen delivery to be low due to hypovolemia. We don't want our patients to be full of edema. And that's how we may have to monitor cardiac output during fluid administration, although in some cases we could just look at heart rate, look at blood pressure, and see how the patient responds to fluid or urine output. So, signs of fluid responsiveness are very important to identify. Not so much to give more fluid, actually even more to limit fluid administration when signs of fluid responsiveness are no longer present. Now, if we want to further increase cardiac output, it's fluid and perhaps inotropic agents, as I say. Our most recent Surviving Sepsis campaign guidelines for the treatment of sepsis indicate that we suggest using dobutamine in patients who show evidence of persistent hypoperfusion despite adequate fluid loading and the use of vasopressor agents. I think that's reasonable. For the last minutes, we had an excellent talk on SaO2. You know, we have given oxygen since the very last years of the 19th century. But many years ago, it was already identified that hyperoxia may hurt the lungs or may actually hurt the tissues. So it's the same U-shaped curve than for hypervolemia. We recently showed that even in healthy volunteers breathing a high FiO2, there is an alteration in the microcirculation. There is peripheral vasoconstriction. And indeed, as Dr. Girardis showed, we may have this curve well documented, this U-shaped curve, and we heard about his excellent trial. I'd like just to call your attention on the most recent study on this by Dr. Asfar and collaborators in the Lancet, where they showed that there was a little bit of a difference in mortality when they gave high FiO2s in their patients. And I wrote the accompanying editorial here, where I say, you know, in the nature, the animals have never been exposed to hyperoxia, if we think about it. It's impossible to have hyperoxia unless someone gives you oxygen. But if there is no medical intervention, you cannot get substantial hyperoxia. So the body has never been adapted to that. So indeed, I concur with what was said, that we should maintain the oxygen saturation perhaps somewhere between 92 and 96%. That's probably a reasonable target. And when a nurse says, oh, SO2 is fine, it's 99, 100%, we should say, wait a minute. I went to Brussels a few days ago. And I can tell you, we are not aiming at 99, 100%. We are aiming at low normal values. And you will explain why, if the nurse is not in the room right now, you will explain why, and people in the team will understand that it is important to keep the oxygen saturation within the low normal range and not above. So don't go to the oxygen bar in Brussels, okay? Don't do that tonight. There is no reason. It will not make you better by any way. Finally, but the next speaker will speak about hemoglobin. It's so important to monitor hemoglobin levels. Perhaps in acutely bleeding patients, the hemoglobin level may still be normal for a while, before there is this transcapillary refill and before we give a lot of fluids to our patients. Bleeding will result in a low cardiac output state due to hypovolemia. Anemia results in a high cardiac output state because there is indeed the compensatory mechanism associated with decreased blood viscosity and the adrenergic response with tachycardia and increased myocardial contractility. So, you know, some people say we should not give blood unless the hemoglobin level is below 70. I disagree. I think it can be true, it can be false, because giving blood may actually change the compensatory response of the patient. So for the heart, it could make a difference. We wrote this editorial with Philip van der Linden recently saying, you know, the answer is in your heart. Look at this study where patients with coronary impairment associated with symptomatic coronary artery disease were randomized for blood transfusions or not. That was not a good idea. No, no. If you go back to physiology, as Gattinoni told us this morning, it's not a good rationale. And they had to stop the study right away, because the patients who were in the restrictive blood transfusion strategy got worse. Of course, if you have a coronary arteriopathy which is active, anemia is not very good for you. Likewise, in the neuro patients, we should be somewhat concerned about a reduction in oxygen delivery to the tissues. So perhaps we need to reassess a little bit our blood transfusions. We will speak about it in other sessions. We should be reasonable, of course. We should not over-transfuse like in the past. But we should look at hemoglobin levels and look at the heart of the patient. And that can actually help, especially if we want to ambulate patients. You know, it's difficult to be ambulated when you are anemic. So in conclusion, when we speak about oxygen delivery, we need to split up the determinants: PaO2, oxygen saturation, hemoglobin, and the 4 determinants of cardiac output. And whenever we try to increase one of these determinants, there may be a price to pay. Too much oxygen, not good. Too many transfusions, no, not good. Too much fluids, not good. Too many inotropic agents, not good. Too much vasodilation, no. Too much tachycardia, no. So, whenever we choose something, there is nothing entirely safe, even not oxygen. So we need to integrate variables and have the proper monitoring system. We need to monitor the individual patient to individualize our therapies. With this, thank you very much.
Thank you very much, Professor Vincent, for this excellent talk. I could listen for hours to